Good morning and welcome to the first meeting of the Norfolk and Waveney NHS Integrated Care Board. It's wonderful to see so many colleagues, friends and partners here today. Thank you all very much for joining us in person, but also many others. Let me welcome those of you who are joining us online with our live stream. And I'm afraid I do need to begin with an apology. We had, of course, arranged interpreters, sign language interpreters, and unfortunately, they have gone down. One of them has gone down with COVID, and they are unable to attend this morning. So many apologies to anyone who was relying on our BSL colleagues for interpreting. I should have introduced myself first. I'm Patricia Hewitt, and I'm the chair of NHS Norfolk and Waveney. And before we move into the business of the meeting, I just want to go round our board table so that you know who everybody is here. Tracy.
Hello, my name's Tracy Bleakley and I'm Chief Executive of Norfolk and Waveney Integrated Care Board.
Hello, I'm Dr. Frankie Swords and I'm the Interim Medical Director of the board.
Good morning everyone, I'm Stuart Richardson. I'm partner member representing mental health and community services.
Hello, I'm Hilary Byrne and I'm the Primary Care Partner Member of the board.
Kathy Armour and I'm a Non-Executive Director and will be Chair of the Remuneration, People and Culture Committee.
Morning everyone, I'm Stephen Corse, Director of Finance for the Integrated Care Board.
I'm one of the Non-Executive Directors and I also chair the Audit Committee.
Good morning everyone, I'm Emma Ratzer, I'm the Chair of the VCSE Assembly and the VCSE Board Member.
Good morning everyone, Hein van Ulmer, Non-Executive Member, and I'll be chairing the finance.
Good morning, my name is James Bullion.
Good morning everyone, my name is Tricia Dorsey and I'm the Director of Nursing for the ICB.
I think colleagues may have to lean forward and be quite close to the mic to avoid the feedback.
Yeah. So good morning everybody, sorry I wasn't leaning forward. I'm Tricia Dorsey and I'm the Director of Nursing for the ICB.
Good morning. Good morning. My name is Bill Borrett. I'm the Chair of the Norfolk Health and Wellbeing Board and I'm the Chair Designate of the proposed ICP, Integrated Partnership Board.
Good morning. I'm Karen Barker. I'm Director of Corporate Affairs and ICS Development and I'm here assisting the board today. Thank you.
Thank you. Now, a few housekeeping points, I'm sure familiar to everybody. We're not expecting a fire alarm, so if the alarm goes off, please calmly leave the building through one of the exits. You can see them marked, and the nearest exit, remember, may be behind you or to your side rather than in front of you. I've welcomed those watching on our YouTube channel. We will also make a recording of the event available on the channel after the meeting. We'll be posting messages and photos on the Integrated Care System's social media channels during the meeting. If anyone doesn't want to be included in a photo, just let one of our staff members know. And staff members are mainly sitting over there, but will also be coming around with roving mics. We have included a little bit later in the agenda an extended question and answer session. So there really will be a good opportunity for people in the room, people watching online, to ask questions at that point. We've already had 4 questions submitted, and when we come to that part of the agenda, we will start with those. But if you're watching online and would like to ask a question, please email nwicb.communications@nhs.net. I'm sure that's on the YouTube. Yes, we will start in a moment with a number of governance and legal matters that we have to do in order legally to establish the new organisation. But we'll get through that fairly quickly. This, I should just stress, is a meeting in public of the board. It's not a public meeting as such. And that's why we're asking you to keep questions until we get to the Q&A session. And when we do get to the Q&A session, just if you would remember, don't share personal information or information relating to anybody else when you are asking a question. Because the meeting's being recorded and going on YouTube, we don't want inadvertently to breach somebody's privacy or confidentiality. But before I turn to the formal agenda, I do just want to set this first meeting of the NHS Integrated Care Board in a little bit of context, because this really is a big day for the way in which the NHS works and the way in which we work in Norfolk and Waveney. Because for well over 70 years, the NHS and the thousands of wonderful NHS staff we have here in Norfolk and Waveney have look after us when we're ill, injured, need that help. And that vital work will never stop. But I think we all know from our own experience that our health, whether it's our physical or our mental health or both, depends on far more than just the NHS, however important the NHS is. Our work, our income, or lack of it, whether we're close to friends and family and neighbours, or whether we're isolated and lonely, our housing, whether we can afford to keep our home warm, what we eat and drink, how much we exercise, all those and many other factors make an even bigger, indeed a much bigger difference to our health and well-being than the care that health professionals can give us. And from today, really for the first time with the new Health and Care Act, the NHS is being asked, indeed it's being mandated, to work with all our local communities, with local government, with voluntary and community groups, with social care providers and many, many others to help people lead, as we say here, longer, healthier, happier lives. And that's why we're all here, because that's what we all believe in. That's why we all want to make a difference. And we've been working here in Norfolk and Waveney for many, many years, building this kind of partnership across the NHS, between the NHS and social care, and with all those wider organisations. And now, with the new law and the new integrated care system, that partnership way of working becomes the norm. The integrated care partnership, which Councillor Bill Borrett mentioned, will be sitting, as it were, alongside this NHS Integrated Care Board, bringing together this wider group of partners so that all of us are pulling together in the same direction. And we saw the benefits of that kind of partnership working in the vaccination programme and indeed the wider work during COVID. So we'll hear more about that today. But I do, at this point, when the new Integrated Care Board takes over the responsibilities of the clinical commissioning group that many of you will be very familiar with, I do just want to pay a real tribute to all of my colleagues who have served, often for many, many years, on the governing body of the clinical commissioning group and its various predecessor bodies. They have done a wonderful work. We are building on those foundations, and I want to thank all of them. I won't try and do so by name, but they have really played an important role. So, we will now turn to the agenda. We have two apologies for absence from the board. Jonathan Barber, who is the partner member for our acute hospital trusts, and Sue Cook, one of the two partner members for local authorities. Declarations of interest, those are all, they've all been made by all members of the board. They're all available in the board pack and published on our website. I don't think any colleagues have anything to add to their declarations of interest. They've all been very recently updated. We then have the action log, and there is one outstanding action that's been transferred to us from an earlier meeting of the CCG governing body, and that is that we will take a report at our meeting in September on maternity. I think everyone will be aware of recent concerns in different parts of the country about maternity services and some very disturbing public reports, and we of course want to ensure that our maternity services are safe and of the high quality that everybody would expect. So we'll have a meeting on that, a report on that in September. We now come to the report that Tracy Bleakley, as our Chief Executive, and I give at, and will be giving at, every meeting of this board. I'm going to turn to Tracy to introduce it.
Thank you so much, Patricia, and thank you to all of you for attending today on what I think is a very, very exciting day, and a day of real change and opportunity for Norfolk and Waveney. Patricia explained what an integrated care system is all about, which is about health and well-being and improving our health and well-being across Norfolk and Waveney. In terms of thinking about the NHS and the big change that we've got from today, it's thinking about a model that works for £2 billion roughly of spend, which is what we've become accountable for today. And in the past, that was done by thinking about all of the different organisations in the system and making sure that those scarce resources were used as best as possible by the people that needed them. And so it often felt as though patients and families and communities had to think for themselves about what was the service they needed, how do they need to access it, what do they need to say to be able to get that service, and then how long do they need to wait to get to the next bit. It almost felt in the past, if you were suddenly ill, you had to find out for yourself how the NHS worked. And it was often different from maybe the last time you checked 5 years ago. The change today that we want to make is to say that actually everyone who lives here at Norfolk and Waveney is at the centre of our system, and we will work together to get rid of those boundaries, to get rid of that idea that you have to justify why you're being looked after by different groups of people and different organisations. We will work together to make sure that people have the health and care they need. Because after all, it's very different, isn't it, from when the NHS was set up. We used to think about health as something going wrong. We don't think about it unless something goes wrong. And the idea is that the NHS is there to help and fix it and put us back together again, and then we leave the NHS service all better and we go back to our lives. But that's not how many of us are living today. We know that so many people are living with long-term conditions. We know that there are phases in our life where we might need more support, which is around early years or frailty or end-of-life conditions. And we also know that there's a big link between physical and mental health. So actually, it's not about fixing people and putting them back together, but it's thinking about how can we support people to be healthy and happy? How can we keep people well as long as possible? What can we do as a system to proactively support you in doing that and look at different patient groups and risk? And we could contact you and say what's available to you to make sure that you stay well. And then when people do need our help and support, we will try and find a way to provide that as close to where you live as possible, so that you are supported to live as well as possible, you are supported with any changes that might happen long-term to your health and well-being, but importantly, we're preserving quality of life. No longer will you have to work around us. We are going to, from today, work around you. Now, just to explain a little bit about the Integrated Care Board, we popped up as a new organisation today, and we've actually taken across the majority of the staff from the former clinical commissioning group. And that was part of this whole different organisation structure in the past. So commissioners basically looked after the money and commissioned services on behalf of the public and made sure those services were delivered well. And they were completely separate from what we call the provider organisations. That might be GP surgeries or hospitals or the community trust or the mental health trust, who individually had a whole host of things that they had to tick to show that they were performing well. The Integrated Care Board brings all of the organisations working together as a system. So there's no longer this split between commissioning services and providing services. We are looking at all the data of what the public need now, but also in the future, and working together. So what that means in practice is you've got these fantastic conversations with the chief execs of the acute hospitals saying, how can you give us less money? How can you spend that money in the communities with the GPs so that they are able to help people closer to home and in their own homes? So we have less people coming into hospital, and the people that are coming into hospital are the people that need to be there. Because goodness knows, wouldn't you rather be looked after in your community, near your own home if you possibly can, rather than that frightening journey, blue light into one of our hospitals, you don't know where you are, you don't know when you're coming out again, and you don't know what's going to happen to you, and your family who potentially can't access public transport find it difficult to get to you. Let's do as much as possible near people's homes, and let's make sure that people are only going into hospital where they absolutely need to be there. So having talked about the change, I'd just like to reiterate Patricia's thanks to everything that's gone before. I'd like to say a massive thank you to our colleagues at the Clinical Commissioning Group, which ceased to be at the end of yesterday. I'd like to say a massive thank you to everybody in this room and all of the people watching and everybody who's been involved in this transition, because there's been a lot of work behind the scenes. Can I just also single out Karen Barker and her team, who never really gets a lot of thanks, but my goodness, the legal forms that she's had to fill in and sign, the documents that she's had to write to make this a reality have been absolutely enormous. So I would like to say a massive thank you to Karen and her team and everyone who's supported that within our organisation. So whether that's the communications function, all of the different meetings that have been having to be pulled together, and the different people in our organisation who've wrestled with some quite difficult problems and tried to pull this together in a way that makes sense. I'd also like to say a massive thank you to anybody who's been working in the NHS through the pandemic as well. It's been a really tough time, and I don't just want to single out NHS colleagues, I want to single out everybody who's been working in the charity sector and the local authorities and all of the different organisations that pull together, and of course the volunteers that all came forward. Because my goodness, didn't that set us up well for working in a different way, for working together, for putting the patients at the heart of what we're doing, and actually properly looking at what's happening and the issues that people are facing, and not necessarily thinking about our organisations or the tick boxes that we've got to tick or what we've got to do to get our governance through. We actually focused on patients, and we'll be taking so much of that learning forward into the work that we do. So that's the background of where we are, and it's going to take an awful lot of work, and we are going to be involving everybody from our partner organisations and also from the public as well. So we're going to be on a journey here. We've got a lot of knotty issues to sort out. We're not going to sort them out on day one. And in my report, I've touched on a few that I know are of great concern to our system, but also to the general public as well. The first one that I've picked out in my report is around mental health services. And we all know that our Mental Health Trust, Norfolk and Suffolk Foundation Trust, has been working with the CQC in recent months. We know that the service is not the service that we would like to be providing for our patients and communities. There's been a lot of work going on, there will be a lot of work going on with the Trust, also with support from the wider system, from the CQC as well, and from the wider NHS England colleagues who've been putting in an awful lot of work to help the organisation with some of the issues that have been identified with the CQC. But what I want to say very clearly is, if we have a provider in our system that is focusing on something very specific like mental health, it is not the provider that's failing, it is the system. We cannot look at organisations in silo. We have to look at every part of our system, whether it's looking at young people and how they interact at school and how they interact with their counsellors, whether it's looking at people accessing GP services, whether it's peer support in the community, making sure that we make best use of the voluntary sector, our community colleagues as well, what happens to people when they go into the hospitals, what happens to people when they interact with the police and the wider determinants of health, and making sure that we're supporting people with employment, with housing, and all of the things that affect people's mental health, as well as linking into physical health as well. So what we're going to be doing as a system is a full system review of mental health. And our ambition is to provide an excellent mental health service for everybody living in Norfolk and Waveney. Again, we won't do it overnight. We will do it very publicly and very openly, and we will involve service users and their families as well in a very open and transparent way. But I want to get everything out there. I want to be totally honest about our failings. I want to be totally honest about where things aren't going as well as they possibly could be. And I also want us to learn from innovation and where things are going well in other parts of the country, maybe in other parts of the world. We're going to be listening, we're going to be changing, it's going to be happening over a period, I think, of at least 2 years, and we're going to be supporting our colleagues to do that as well in all parts of the system. But I just want to be very, very clear that mental health is going to be a big priority for us as a system. The second area I wanted to cover was general practice, and I know it's a huge concern to people about accessing general practice, because often that's the front door, isn't it? When you have a concern, you want to be able to talk to somebody about that, and you want to be able to do it quickly. Now, it's interesting in terms of what's happened to general practice, because I think we had a couple of years over the pandemic where people tried not to bother general practice. We tried not to think about our own health. We tried to prioritise COVID and the pandemic and those of us in the community that needed help most. And now, of course, people are coming forward, quite rightly so, and we want people to come forward. We know that people are having access issues, especially in different areas of the patch, and we are looking at that and looking at how we can support that and make sure that people have the access they need. It's not always about access to a GP, so we're looking at who is the right person to deal with different issues and making sure that we're really open and transparent about that, because goodness, it can be very confusing, can't it, knowing who to contact. So we're looking at doing that. We're looking at supporting our colleagues who are working on reception as well in the GP surgery to explain that. And for the people that can get online, we're making sure that we can book digital appointments and have digital interaction with GPs, but also with nurses in the practice as well, and peer support workers and anybody that you might need to contact. Also, of course, making sure that we're linking our community pharmacies, who are hugely important, as well as 111 services and other services in the community. It is important to say that more people are accessing GP surgery now than they were before the pandemic. So we are seeing an uplift in Norfolk and Waveney in terms of the numbers of appointments. And we are higher than the average in the country in terms of face-to-face. So it's around 71% of appointments, GP appointments in Norfolk and Waveney are face-to-face versus 63%, so nationally. So it is important to understand that and to understand the context. But we know that it is confusing for the public, it is frustrating, and when people are waiting and they're not sure how to access, it does mean that potentially we're not picking up problems as early as we could be. So it's going to be a priority for us to look at that. And we're also, many of you will have seen in the press again today, that we are concerned about GP numbers. So we're really looking at recruitment, about retaining our GPs as well, so making sure that they don't want to retire or leave or do other things, but also thinking about other roles and other specialities that we can get into GP practices to expand the services that you can access straight away through your GP surgery. So again, we'll be talking a lot about that in future meetings. Finally, I just want to talk about system pressures. Many of you will know that we have pressures with our ambulance services and we have pressures in A&E in our hospitals. That's happening all across the country. We know we're having those problems in summer, so we're already planning for winter. We know that fewer people are ringing 999 and going into hospital, so we've done great strides with the public in understanding when it's appropriate to go into hospital. But we still think we can do more in terms of providing services in the community, and that's something that we're going to be looking at. So especially for older people who are frail, just to give an example, where we can provide services rather than taking people into hospital. One of the big concerns that people often have when we talk about discharging people from hospital is that often we'll say somebody is medically fit, or we'll use terminology like not having criteria to reside, which doesn't make any sense to anybody. Actually, when we talk about somebody being medically fit, they could often need quite specialist nursing services. But what we're saying is that the hospital isn't the right place for them because the services provided in the hospital are no longer appropriate. What we might want to do, for example, is allow somebody to go home, but we might need domiciliary care to go in and support those people with general living 2 or 3 times a day. Or it might be that they need to go into a nursing home or a care home and have rehabilitation or nursing services to support them. So we're looking at ways to make sure that the hospitals and the care services work much more closely together, that we can explain patient need much better, that we're not relying on families to sort this out or tell their story multiple times, and we're really looking at that. But one of the things I wanted to say is it's going to be really important for us as the system, not just to focus on the crises we have today, but to also think about the future. And the way that we're going to do that is every single time we have a crisis, we think, how do we solve this today? And how do we know it will be different in a year's time? And as long as we think about those two things at the same time, I hope that we'll make sure that next winter and the following winters, things will be different. So that's my report.
Tracy, thank you very much indeed. That was a really helpful overview, I think, well, I hope for everybody. Now, are there any questions or comments on our report from board members? Oh, trying to see everybody is a challenge in this room. No? Tracy, I think you've answered every question board members might possibly have on that. Good, thank you very much indeed. So we now, and I was going to thank Karen at this point myself, but you've done that beautifully, Tracy, and I would simply echo that because I have seen the extraordinary amount of work that it has taken to handle the sort of organisational and legal process of moving to the creation of this new body. So I'm now going to hand over to Karen to take us through this section.
Thank you, Chair. I will go through an introduction first and then turn to Patricia on each point so that we can make sure we approve it, and I'll try and keep this as to the point as possible because I appreciate it's not the most interesting of subjects for everybody in the room, although it is for me. As you'll all know, today the ICB was legally established and the board was appointed this morning by Patricia as chair. So now it's just for us to go through a few key documents to complete the establishment of the ICB.
Right, so we start with the Constitution.
Constitution. So the Constitution has already been approved by NHS England. It is not for the board to approve that today, but we thought it was very helpful to bring that in the public domain so that everybody could see it. And in simple language, the Constitution is the rule book that the ICB will be ruled by. So anything that anyone wants to know about decision making, it's all included in the Constitution. So that's just to note.
Yeah. And that's available on our website, I think,
it's
already.
It's available on the website already.
Good. So is the board happy? We just have to note that. Wonderful. Thank you very much. So then the Governance Handbook.
The Governance Handbook is how we will ensure good governance across the ICB. It includes in particular various policies, including the petitions policy and standards of business conduct that the organisation will work to. It also includes the terms of reference for all the committees of the ICB, of the board. So again, I need that for approval in this instance.
So is the board happy to approve that? Thank you. That's unanimous as well. Right, next one.
The next one is the policies, approvals and transfer. So as we've already heard, the CCG was abolished by a statutory order today. So we are asking that all the policies of the CCG are transferred over. They will be reviewed in accordance with their usual review dates, and in particular, we seek approval of the complaints policy.
Good, thank you. We're happy to approve that. Thank you very much.
The next one is about the emergency arrangements of the ICB. So this is the arrangements we have in place in line with if there is an emergency within the Norfolk and Waveney system. So we just want you to note the contents of the paper, but in particular to approve the appointment of the emergency accountable officer, which would be Dr. Frankie Swords. and that Dr. Swords will also co-chair the Local Health Resilience Partnership with Dr. Louise Smith, who's the Director of Public Health.
Good. Are we all content to approve that? Good. Thank you very much indeed. Thank you, Frankie. Right.
The next one is the Board Assurance Framework. The CCG, at its final meeting on the 24th of May, reviewed the risks of the CCG, and these have been formally transferred over to the Integrated Care Board. We do need to now receive those risks formally today. I did want to say, though, that we will be doing further work on those risks. And the directors that you see both on the board table and seated over there will be reviewing those internally, and we'll be looking at them more now as a system rather than a CCG. So there is some more work definitely to do on that board assurance framework, but it's here today so that the board can formally receive those risks from the CCG, and there'll be more detail at later meetings.
Good. Board content with that? Thank you. Then we come to board leads.
Yes, in the paper there are a number of board leads and champion roles. There are lots of other responsibilities and roles that directors have, but the formal ones that we need to approve at the board today are listed within the paperwork, so I'm asking for those to be approved, please.
Everyone happy with that? Thank you. That gives us our committees.
Committees.
That gives us our leads, apologies.
Yeah, getting there. No. So with regard to the board's committees, we have agreed the terms of reference within the governance handbook, but I need to formally agree the establishment of the committees and also the chairs. That's set out again in the paperwork. We also need to agree that the Integrated Care Partnership is formed. As you'll all be aware, that's a statutory committee of both the ICB and also Norfolk County Council and Suffolk County Council. And we also need to agree that a founder member is put forward. So this is not the chair of the ICP, and this is not the ICP member, it's just a founder member, and we propose that that's the Right Honourable Patricia Hewitt.
Right, thank you. So are we all happy to approve the committees, the establishment of the Integrated Care Partnership, and myself as the founder member as required by the Health and Social Care Act? Thank you very much indeed.
Madam Chair, do you think for the benefit of everybody we could just have a list of the committees and the chairs? We could just very quickly read them out.
Read them? Yeah.
Yes. Karen, I've probably got that to hand quicker than I have.
Hopefully. Yep. Okay, so the committees are the Audit and Risk Committee, and the chair is David Holt, non-executive member. The Remuneration and People Culture Committee, and the chair is Cathy Armour, non-executive member. Patients and Communities Committee, and that chair is to be appointed. We will be having a fourth non-executive member, and we're up to recruitment for that currently. Then there is a Finance Committee, and the chair for that is Hein van den Wildenberg, non-executive member to my left at the end. There's Primary Care Commissioning Committee, and the chair of that is James Bullion, Local Authority Partner Member. Quality and Safety Committee, again, the chair of that will be the non-executive fourth member, but for now it will be Cathy Armour, non-executive member. We have a Performance Committee, and the chair of that will be Dr. Hilary Byrne, who is to my right. And we have a Conflicts of Interest Subcommittee, and David Holt is our Conflicts of Interest Guardian, and he will chair that committee.
Thank you, Karen. Bill, thank you for suggesting that. And of course, that list of committees, the chairs and their members will also all be on the website. Right. And then we have agreement of board dates. Those have been circulated. I think there are one or two slight problems, but we're ironing those out. So again, just that's really for the board to note and approve. So that is the end of the formal governance stuff that we needed to do. And we now move into this really important section of our agenda, which will be part of our agenda for all future meetings, which is about learning from people, from staff and communities. And I'm delighted that we have with us at this meeting Patrick Peel, Chair of Health Watch Norfolk. And Patrick, would you like to come and join us, because you're going to join us for the question and answer panel. So I think at this point we can say thank you very much again to Karen for steering us safely through the legal and the governance piece. But before we come to the Q&A session, we're going to hear, I think, some very interesting work that has been done with carers in Norfolk and Waveney. And I'm going to hand to our new Director of Nursing, Tricia Dorsey, to introduce this item. Tricia.
Thank you very much, Patricia. Yes, I'm the new Director of Nursing, first day today, and I'm absolutely delighted in the focus that we have today on the voice of not only our patients but carers and communities. It's imperative for the Integrated Care Board going forward that we truly have an opportunity to hear stories so that we can think about how we work together across our partnerships for the future. With regards to the focus of the story today, we're focusing on the carer's experience. Now, as we become an ICB, there is a focus on legal responsibilities for carers. And so I think it's very timely that we think about that in the discussions that we have today. So we've got some short clips, and then we're going to hear from colleagues who are working in that area, and then I'm hoping that there will be some questions around what we can do to help and support carers more effectively for the future. So if I hand over to my colleagues in comms, I think we've got two stories today.
This is on video.
On video.
And for board members,
Up here.
there are two television sets, which are probably easier for us to see than the big screen. So, yeah, we can.
Thank you, Patricia.
Thank you, Tricia.
Apart from personal care, mainly making sure she's taking medication, cooking, helping her up and down the stairs, helping her around the house. I'll do shopping for her, make sure that everything is ready to go for the next day, or basically look after the house and her. The end of September, Mum had collapsed and wasn't right. I ended up calling 111. When I first went in to see her the next day, she was with the doctor. We explained everything that had gone on. It felt like we were getting spoken to. Everything was fine. I wasn't concerned that they were going to send her home too early because everyone was just trying to get stuff done. She then moved ward. That's when things started going downhill. I didn't feel like I was getting listened to at all. While she was in, I had to call the GP to see if they could talk to the hospital for me because no one was listening to me. And they said there's not a lot we can do because we can't override what the hospital are doing. She was having medication changes that wasn't being communicated to her, which would stress her out more. I couldn't get anything from it because I wasn't next of kin, so they wouldn't talk to me. The experiences would put a lot of stresses on me. She called me at midnight on a school night in floods of tears because nobody was listening to her. I lost all faith in the hospital, treating her the way they were and not really listening to me either. No matter how many times I said, I am the main carer, I am the one who is looking after her, nothing was brought forward. To be honest, I don't even think anything was actually put down on the notes, despite Mum being told there was, because I feel if it had been put on the notes, they would have spoken to me. It was while she was still in hospital, and I was living on my own at the house. I had the mental health team call me several times thinking she'd been discharged. I had occupational therapist at the house thinking she'd been discharged, which added more stresses because I'm thinking, well, why haven't I been told all of this? And is she being discharged today? Is there stuff going on that I've not been told about? And it just seemed to go on forever. I asked countless times, can I have a meeting with the discharge team and her clinical team before she gets discharged, so I'm aware of everything that they've done, and concerns that I have been raised and answered. That never happened. I ended up having a meeting just with a discharge clerk. There wasn't a lot he could answer, and she was discharged with the wrong care plan, so they signed her off, and then we've heard nothing. The occupational therapist has been in and assessed her over the phone because of Mum's anxiety. She doesn't like people going in the house, so Mum would have been more open had they didn't get to see her physically assessed. I would have liked them to have just put a foot down and gone, no, we've got to assess you at home. After she'd been discharged, there was not really any involvement with me at all. And I just felt really let down by the hospital, and I'm worried about her going in again. I would like the hospital to recognise the triangle of care between patient, clinician and then carer, that everyone is actually included in the treatment and in processing care and discharge plans, because at the end of the day the carer is the one who's got to implement that plan to an extent. They need to know what's going on, especially as a young carer. It worries us if we don't know what's going on at home. So if we know that on a Tuesday there's meant to be a carer coming in, that's fine. But it would be nice to know that, not have to wait until discharge, especially for the older young carers, the teenagers, given the fact that they are on their own, especially if they're on their own, with the person who's being cared for.
Sorry, there's a second one. Sure, okay.
The person I care for is my husband, and he started to become unwell really just before he had to retire from work, so early 60s. He's now 77, and his condition has got gradually worse over that time. So I've seen myself going from somebody who was being helpful to him and assisting him to somebody on whom he now really does depend. When he's been in hospital, I've noticed that there's very often quite a change from when he goes in and from when he comes out. And it's really difficult for me to know what those changes are going to be. And as I'm absolutely on my own here, as I don't have any family near me at all, I know that as a 75-year-old now, I have got to cope with whatever comes my way. So I suppose there's always an anxiety that he will come out when he's ready to come out. There's always that anxiety. You want them to come home. You're looking forward to them coming home, and they want to get home. But it's how that happens. When the discharge goes well, it's just a pleasure to have somebody coming back into the home with whom you can cope and who you see is much better than when they first went in. It's a relief. You feel secure again because somebody has come back to you and you're able to manage them, you're able to help them, and hopefully you're able to help them get even better. So the negative impact for me as a carer is fear. I become afraid. I'm afraid that I can't manage my cared for. I'm afraid he may fall, for example. There might be aspects of his care which have changed and I've got to come to terms with. So staff who are going to support unpaid carers, I think they should be able to try to understand where the carer is coming from. This isn't a bossy wife or a bossy mum. They're people who have had experience and are afraid for themselves as well as for their cared for. They want to know they can cope. They want to know they can give the very best to their cared for. So anything that staff can do to understand where the carer is coming from would be a very good thing. If you don't involve us early in the process of discharge, we are automatically worried from the very beginning. We're trying to get in. Who do we tell? Who should we approach? Is it the ward sister? Is it the discharge team? Who are we going to go and see? Will those people be available even when we are on the ward to see our cared for? If I could say anything to your workforce at all, it would be please listen to me. I might not be very articulate. I might be worried I might be a bit angry because I'm worried. I might come over completely wrong. Please just take the time to listen to me. It's really important to know that they are reporting back any problems that we're having. So if I say we haven't got problems here, it's wonderful to know that they're going to write that down somewhere on a report. It's going to go back, and that when reassessment takes place at the end of the time, all of those things will be looked at, and maybe if things need to be put in place, they can be. I think, again, it's a teamwork situation. I will notice things that may be very important, but I'm equally very aware of their expertise when they come in.
I think those were two really moving accounts, and I think any of us who have had experience of supporting an elderly person or someone who's had other illness would recognise those experiences. So Tricia, I believe we're now going to hear from Sharon and Belinda. Is that right?
Chair.
Right, so over to Sharon and Belinda, please, and will you introduce yourselves properly to everybody? That would be great. Yes, just face everybody, that's fine, the board is not going to object. You'll need to hold that mic probably. Good morning, everybody. Hold it closer to your mouth, there might be a little switch, I wonder.
Hello? Get really close.
Right, okay, thank you. Good morning, everybody. Much better, thank you. I'm Sharon Brooks. I'm Chief Officer from Carers Voice Norfolk and Waveney. I'm here this morning with my colleague.
Hi, I'm Belinda Jones. I'm an Awareness and Voice Team Leader, and I work for the charity Caring Together, raising awareness of all unpaid carers. Thank you.
Carers Voice and Caring Together have been working in co-production with carers and practitioners within the ICS to improve the identification of carers within Norfolk and Waveney. Some of the carers we've been working with are here today. However, we are aware that it is often very difficult for carers to leave the person they care for, and by producing videos such as the ones you've seen, this enables their voices to be heard across the integrated care system. We want to ensure that there's a coordinated approach with the ICB and across the ICS so that carers are identified and supported in line with their new legal rights under the Health and Care Act 2022. Next slide, please. Thank you. Carers Voice has been co-producing with carers the first all-age carer strategy for Norfolk and Waveney. Through this consultation, carers have told us of the fragmentation of services that they experience within the health and social care system. Carers frequently have to tell their story multiple times with lack of communication between services and departments and not being recognised, valued and involved in the care of the person they're caring for. The videos you've just seen clearly demonstrate the need for coordination across the system, particularly on discharge. If the patient and carer are supported with the appropriate services, they will be able to continue to live in their own homes and communities. Too often, carers feel ignored with regards to their knowledge and lived experience. Building on previous work on the co-production project, Carers Voice will develop a task and finish group bringing those involved in discharge together to co-produce improved discharge processes. It is very positive to see the review and simplification of the process for assessment and referral to discharge to assess as one of the priority actions of this board, and carers will work with you on this. Carers have told us that they wish to be identified as a carer at as early a stage as possible, so that they are valued, respected, listened to, and involved in the health and care pathway. The co-production project has identified a carer's passport as key to ensuring carers receive early identification prior to hospital admission, so that they can be recognised and valued as experts by experience before crisis hits and can be involved in discharge plans at an early stage. As well as reducing the need for carers to have to repeat their experience multiple times, it would reduce the extreme levels of anxiety and stress that carers frequently experience. It would increase public awareness of the caring role, enable links to support in the community, reduce barriers at GP surgeries, and young carers have also told us they would value this early recognition. This passport would accompany the carers throughout the ICS, and carers would welcome its early implementation.
At Caring Together, we have been working very closely with the Acute Trust along with Norfolk Community Health and Care for a number of years now. We regularly deliver awareness-raising training across the Trust, enabling healthcare professionals to have an awareness of unpaid carers, and have recently been delivering more targeted sessions to different departments, including the cardiac team, the community neurology teams, and crucially to the discharge coordinators. With co-production at the heart of everything we do, we held focus groups for carers to look at our training presentations, to let us know if there were any glaring gaps or enhancements they would like us to make. Overall, the feedback was good, with the main area lacking was around parent carers, which we were already very aware of and have taken on board. We will also ensure, once completed, that the carer's passport is embedded in our presentations, enabling practitioners and healthcare professionals to be aware of its existence and to be able to promote it to carers.
Next slide, please. Next slide, please. Thank you. We request a designated carers lead within the ICS who will be an advocate for carers, demonstrating leadership with the authority to ensure that change can be taken forward and achieved. The carers passport needs to be implemented across the ICS. Carers are still currently waiting for the commitment to this from the ICS. Mandatory carer awareness should be supported across the system. The development of the discharge task and finish group should be supported by the ICB and across the ICS. Above are the key recommendations to be taken forward and are contained within a co-produced paper for the ICS from the project group. Many thanks. Thank you.
Belinda, Sharon, thank you both very much indeed. That was really, really interesting. And I was, in fact, just commenting to Tracy that one of the things I think we need to do, although unless it's already been done, is have a look at the shared care record, which is going to come into effect in the next few months and will make a real difference in terms of getting much more integrated care across the system. And, you know, we're working within a national framework on that, see whether that has actually got or could be adapted to have space within it for the key information about the carers, because it's going to be a very important tool in enabling all the professionals who are looking after a particular person to have the information they need. But are there questions or comments from board colleagues? Let's come first of all to Kathy, then I'll come to Frankie, and then to James.
Thank you, that was really interesting. Can I just ask what feedback you've had from carers where you have rolled this out about the benefits it's brought to them?
Sorry, which element are you referring to?
Sorry, the carers passport.
The elements that carers would really request from the carers passport is early identification. So it's particularly before a carer comes into a healthcare setting, so that they are supported to be able to be with their carer in the ambulance for different services outside of the normal healthcare setting, the hospital settings. It can help reduce barriers with GPs, and it can also promote their confidence, their self-esteem. It means that the information they have for the carer, built up under a lot of years of experience, can be used. There may be knowledge on medication. For people presenting particularly perhaps with early signs of dementia, it's quite difficult to assess them, whereas the carer will have an in-depth knowledge. So it's really about being recognised, valued and respected, and from that flow the other areas of issue.
So, sorry, have you had feedback to say that where you have rolled the passport out, that it is working well and it has made a difference?
Sorry, it's not been rolled out within Norfolk and Waveney,
right,
but we've certainly done some research, and particularly with regard to Leicester and Rutland, and they've had a very successful carers passport there. That certainly started during COVID as well, and that was with regards to getting early identification, but it has also been rolled out in other areas. But we'd be very, very keen, and carers are very keen, to have this rolled out as soon as possible within Norfolk and Waveney so that it supports them in their caring role.
Okay, thank you. Thank you. Frankie.
Thank you. I wanted just to pull out a few of the words from those presentations because I thought they were so powerful, and then I'd like to share a sort of a personal experience from working in our healthcare system. So the words that really struck me was the voice of James and Ellen saying they felt ignored, not listened to, afraid and anxious. But then they also reflected, Ellen reflected, that she could feel relief and secure when she is listened to. And I thought that was incredibly powerful. And it reminded me of our experience during the pandemic, where as a hospital consultant, visiting was restricted. And not just for people who have a confirmed caring requirement, but for everybody. Actually trying to care for people without the support of their visitors and their loved ones and the people who know how they like to be referred to, and actually you need to go use their good ear, and actually, you know, they really don't like being called Betty. That's what they were called at school. Just transformatory, getting visitors back because we have that depth and richness. It makes all of our jobs easier. So speaking selfishly, it makes it easier, as well as it obviously makes it better. And the other thing I just wanted to highlight was, although James talked about having been his mum's carer all his life, and Ellen, it was sort of 10 or 15 years, I think, mustn't it be, from her early 60s to 75, and yet they weren't necessarily next of kin, so they weren't recognised as having a formal role, which makes it very difficult for people who are trying to do the right thing and following information governance. So he slept well, but I can't tell you much else. So I think having the carer's passport, it should revolutionise that. We have an official recognised role. Great. Oh, there's a carer. Good, I can speak to them, and as early as possible. So thank you. I think it's a fantastic opportunity.
Great. Thank you. James.
Very much for the presentations, which I think are, really gets to the heart of really what the ICS should be about, actually. And I wanted to start by just the important acknowledgement, actually, that carers, if carers did not exist and did do the caring that they do, actually the health system couldn't function, and certainly the social care system relies upon informal carers to do a job of work, actually, which has a financial benefit value to the system. So I think, as well as the right morality in the recognition and the values of the ICS, there is a benefit actually in investing in this approach, in the advocacy, in the recognition, and in the practical implementation of things like a passport, which will actually in the long run save us money and improve outcomes for people. I really liked in the presentation from James the notion of the triangle of care. It's a really good representation of an equality or an attempt at equality of relationship, and I think that's would be a good thing to promote that notion. I suppose my question really was, I'm acutely worried about the health of carers themselves. I'm very much seeing the evidence anecdotally and in work at people near to the end of their tether sometimes. So I just wonder, what more could we do actually to, as well as recognise carers as participants in the cared for, address the health needs of carers themselves? Thank you.
Thank you, James. I think one of the key things that carers want is to know that the person they care for is being looked after. So that is one of the key issues that's come out of the consultation, and it's something that carers tell us so frequently. If the care for the person they're caring for is right, if they're able to access services, that takes a lot of the crisis away from them. Carers will often spend at least 2 to 3 hours a day trying to contact services, trying to make sure that services are coordinated. So I think that is the key area that carers would want, if there can be coordination of services for the person that they care for. And I think it's particularly access to effective services for mental health. I think the difficulties that carers have accessing services has a huge effect on their mental health. They often feel they're the only person that is holding it all together, and it's a huge pressure for carers to have. I mean, there are obviously also the other areas that perhaps not going to the GPs themselves, that all the care, all the time, all the thought is going for the person they care for. But I think the huge thing is to get the care for the person they're caring for right, and make sure that there is coordinated services. So often carers, they don't know what is happening. They're not told what's happening. There are waiting times. Sometimes carers, if they're told, if they're given an honest opinion of what will happen, that this won't happen for so many weeks, but this will happen then, that will help them enormously. Being left constantly phoning up, trying to contact services is just so demoralising. And if you're looking after somebody that you care and love for very much, it's a huge pressure for you to cope with. Thank you.
Thank you. Other questions or comments? So, yes, David.
And thank you for bringing those stories, because it just reminds us, I think, as a board, how hugely important it is that we ground ourselves in our patient stories and not some of the other items that we've patently had to go through today. I think what it's reinforced for me is the point that Patricia and Tracy made earlier on in the meeting around the breadth of responsibility that we have as a board, because what we've heard today are two very particular stories that focus in on acutes, and it would be very easy to say the problem sits with acutes, but for many of us who have been carers, and you have lived experience all around this table, we have suffered this at the hands of social services, where you're not listened to, or you are pigeonholed because you're a particular race, colour, gender. You have this when you talk about sheltered housing for your own relatives and for care homes. So I think it's a real issue that, with the ambition that we have as a board, we should be tackling across many fronts. It patently was obvious here from the acute front, but I really just want to remind my colleagues around the board table that this probably applies across many of the fronts where carers come into contact with professionals, be they within the NHS or within the broader ICS and partnership universe that we're talking about today.
Yep, absolutely. Thank you, David. Any other? Oh, Hilary.
I was just going to say, from a primary care perspective, I recognise a lot of what you say about the... Can't hear me, sorry.
Don't move the mic, just get closer.
Okay. Can you hear me now? Yeah. I was just going to say, from a primary care perspective, I really recognise what you're saying, and the skill set of carers often leaves me in awe of what they manage on a day-to-day basis. Some of the people I come into contact with manage very complex patients at home in very difficult situations, and they have a lot of technical skills that you wouldn't necessarily expect carers in the community to have. Knowing who to contact is absolutely crucial, and having that relationship with the patient's carer is really important. And as Frankie said earlier, it makes our lives so much more easier. It makes care safer because we have that contact with somebody who knows that person, and they have that individual knowledge. So yeah, a carer's passport sounds absolutely a really, really good idea, and having that information all the time as to who is the most important person in that patient's life to contact would be really, really crucial. So thank you.
Could I just jump in? And all of what you've said, I think, is absolutely true, but just to be inclusive of young carers, because all of what you're saying really lends itself to them. James was 17 there, but he had been caring for his mum since he was in primary school. So really acknowledging them as a whole within the group of carers. And just going back to the comment that James said about the financial aspect, one of the slides that I use in the training, it's kind of my last powerful slide, is how much do our unpaid carers save our economy a year? And I think it's £136 billion. And then we reference what the budget for the NHS was in 2018-19 was 126 billion. So you don't have to be a mathematician to work out that this amazing cohort of people are saving our economy an awful lot of money every year, and we have to ensure that we are caring for the carers.
Yeah, absolutely right. Thank you for making that point, Belinda. Stuart.
Thank you. The triangle of care. So I'm really interested in this because many organisations sign up to the triangle of care, don't they? What's your experience across Norfolk and Waveney of organisations who are absolutely implementing it? And do you see that as part of the mandatory training that you're talking of, that we go back to the real basics of what is expected of people in services?
Excuse me. I think the triangle of care is, is an example of best practice in action. So essentially, everything that... Sorry, my throat's excuse me. Everything that Sharon just referred to about carers wanting to be listened to all falls under that. So the triangle of care should be promoted everywhere because it really is the best example of how to listen to a patient, and they are very often the best historian for the person that you're caring for. It makes sense. It makes sense to be using the triangle of care in every care setting or situation.
Good. Yes, we'll take Bill, and then Tricia, I'll come to you just for a little wrap-up on this item.
Thank you. Can you hear me? Right. What struck me as a layperson is this is a very simple thing, and I suppose one has to ask the question, why isn't this happening already? What are the barriers to this behaviour being established in the system? And do you have any insights on that?
I personally think one of the key barriers is awareness. So healthcare professionals or practitioners having the awareness to know who a carer is. You'd be surprised by how many training sessions I deliver. And there is an NHS definition of a carer which very clearly states and covers young carers and all sorts of the whole broad range. And even people within the NHS didn't know about it or don't really understand. So I think the key barrier is awareness. It's everybody knowing who carers are, what they do, the impacts, and the services, vitally the services that are available out there, of which we're really lucky in Norfolk. There is a lot of support out there. It's making sure that carers are identified, recognised, supported, and I think it all boils down to awareness, hence why we are trying to get awareness training for healthcare professionals as mandatory. Do you want to add to that?
Thank you. I was just going to add self-identification as well. Many carers don't identify themselves as carers. They will often have been looking after a member of the family for a considerable number of years, and then things will gradually become so that they have more of a caring role. And we mustn't also forget parent carers who have a vital role, and I think supporting them is absolutely crucial for the work that they do, and it's something that we would really want to promote at the moment. They have not been included as much, and we would really want to make sure that parent carers are included going forward, and we're working towards that. But I think a lot of it is self-identification, as Belinda said so rightly, carer awareness as well. And also some barriers of people just not recognising, not being aware of what a carer does, but aware of the knowledge that they have. And I think it's, it just needs to be taken forward so much.
I would just, I would add to that in answer to Bill's question. I recently was at the Norfolk and Norwich when Amanda Pritchard, who's Chief Executive of NHS England, was on a visit. And we went across to the A&E, to the emergency department, and we were talking to this brilliant emergency consultant who was talking about how they were really trying to get fast diagnosis and treatment of people who didn't need to be admitted to hospital. So it's like having a GP at the front door, really. But she said, we haven't got the information we need. And many of you will know that one of the most important bits of work that we are working on is electronic patient records across our 3 acute hospitals, because we haven't got them at the moment. So this highly skilled, brilliant emergency care consultant was describing how she and her colleagues, faced with somebody who they just wanted to stabilise, treat, organise perhaps a GP follow-up appointment for and get home, they were having to scrabble around, literally with bits of paper and, you know, post-it notes and such like, to try and work out who to phone, who was the carer, who was the family member, who was the person, the neighbour even, who could they talk to? So the carer's passport, the shared care record, the electronic patient records as they come in, give us an opportunity to make this kind of information available, but I think also just to prompt staff, who of course are working under intense pressure at every point in the system, just with anyone who's got a complicated or a chronic condition, just to check, is there someone in your family, or is there a friend, is there a neighbour who particularly supports you? Because, as you say, the carers themselves won't always define themselves as carers, and if the patient isn't asked the information, well, it'll be missed. Good. I thought that was a very, very interesting discussion and very much summed up how we want to approach our work as a board. Tricia, do you want to add any final reflections?
Thank you so much. I've been really, really excited about the presentations today, and more importantly, the attention from board members about the importance of this agenda. Some of the words following on from Frankie's lead that I was really impressed with was the words listen, the importance of ensuring that the carer is part of the team that is wrapped around to support that individual. So we need to think about some cultural change to make sure that that happens. The importance of partnerships, which is what the ICB is all about going forward. And the need to actually look at the recommendations made by our presenters and our colleagues today to think about how we take those forward as an ICB, so that we just don't listen to the patient's story, but we actually change what we do as a result of it. So with your agreement, Patricia, I'd be very keen to follow through with those recommendations about a task and finish group, and to meet with Belinda and Sharon to talk further about how we can do that together across our partnership. And I hope that we can build on this theme of patient stories for the future, because I think they're so important. Or let's call them people stories, which will probably be better.
Well, yes. And I think actually we are learning from these, and that's why we've headed the agenda item. But Tricia, thank you very much for that, and particularly for that recommendation about follow-up, because I was going to suggest anyway that this should go onto our action log, please, so that you can work out the timing, but so that at one of our next meetings we have a report, please, on the follow-up action from this presentation. We've had actually a question online from our audience on YouTube. Will carers' passports be put as an alert on clinical systems to help with the identification of carers? I think that's exactly what we need. So again, in our minutes and action follow-up, can we please pass that over to our digital team, please, and Mark and so on, to just get that, sorry, Andrew, I think yourself and the new digital lead to take that one forward. And perhaps we could hear what might be possible on that in the follow-up report from Tricia. Okay, so that into the action log, please. So we've dealt with those two things. Right, Sharon, Belinda, thank you both very much indeed, and through you, thanks to James and Ellen for talking to us in the way they did today. Yeah, good. They certainly all deserve it. Right, so we now come to our question and answer session, and we're starting to get some other questions coming in online, and in fact I'm going to take another one from the online immediately because it referred to the earlier discussion we had around committee chairs and governance. And so the questioner has asked, Karen Barker mentioned there's a non-executive member position out for recruitment. This will be the chair of the Patients and Communities Committee. Where is this advertised? It's not on the website or NHS Jobs. We haven't yet advertised it? No. Right, so we expect that role to be advertised next week. If there is anyone either online or in the room who might be interested in that or would like to pass it on to their network or organisation, please just let one of our staff know or email us, and then we can make sure that we actually send the advertisement and recruitment pack to you. It's a really interesting and important role, so I'd encourage people to look out for that one. Right, we have had, sorry, I'm just turning to my questions. We've had 4 questions notified in advance, and because it's always helpful if people do submit questions in advance, I'm going to take those first to sort of encourage people in future. Now, we have a very interesting and important question about cancer, and particularly waiting times for gynecological cancer care. Is that questioner present in the room? Because we don't know that person. Because if you are, you can ask the question yourself. Doesn't look as if they are. Let me take it anyway, because it really is important. So the questioner wants to know when our hospitals, in this case it's the Norfolk and Norwich gynecology team, going to follow cancer guideline targets. The 2 weeks referral they were late doing, and the 31-day start treatment plan, I'm now 3.5 months and haven't had any treatment, 0 treatment. So far fobbed off with another number and then another number to get a surgery date. So my question is, when are the hospitals going to start treating patients? Frankie, can I come to you on this? Obviously we don't know the details and wouldn't refer to them for the particular patient, but on the general issue.
Of course. So the first thing I wanted to say was that I'm very sorry for this individual, and that others are also waiting too long. It is too long, and we as a board and the NNN board in this case are both aware and committed to improving that. I don't want to give excuses, but I do think it's perhaps useful just to talk about why we are struggling, as well as what we are doing about it and how it's starting to work. So firstly, this question was about gynecology 2-week waits, and we currently have a 10% increase in the number of referrals. So we're used to jogging along, roughly the same number of people referred to each clinic at any given time. There's been a bump up, and that will be partly because, as Tracy mentioned earlier, people weren't coming forward at the height of the pandemic, and we need them to come forward, and it's right that they come forward if they have got worrying symptoms now. So we've got a bulge of extra people needing to be seen. But of course, during the pandemic, the people who see them, the doctors, the nurses, the admin staff who organise those clinics, they've also had COVID, or had caring responsibilities, or had isolation. So it's actually more difficult for us to catch up, as well as this bulge. So that's why it's difficult. What are we doing about it? Well, I think there's sort of 3 things we're doing. Firstly, we're trying to see extra. So we're putting on extra clinics and extra operating lists. We have a sort of a mantra across the hospitals: use every list, fill every list, put on extra lists whenever you can. And that's how we're working at the moment, to try and catch up. But secondly, we're looking at the referrals, and making sure we do the most urgent people first. So the doctors and nurses who work in those teams are continually reviewing, we call it vetting the referrals. How urgent is this one? Oh, well, I know I was going to do that one next, but this one's even more important. Continuously rejigging in line with the risk. And then thirdly, we're trying to look at, gosh, well, we've had this huge increase in demand. Actually, the vast majority of people referred won't end up having cancer. So can we try and do more to make sure that we get the right information and the most important people referred on that 2-week wait? And if the other people still need to be seen but aren't quite as urgent, let's make that clear. And so we're doing lots of education sessions with primary care, for example, to say, actually, who are the most urgent people? So increasing the capacity, using it for the highest risk people first, and thirdly, trying to do what we can to address the demand. Because of all this bulge, unfortunately, people are still being seen later than we'd like and having their tests to confirm what they need, or if they need anything, later than we'd like. And that does mean that people are then getting their treatment beyond that 31-day target. But it is starting to work. And so because we got this one in advance, I was able to look up the figures. And so I can say that for gynecology at the NNN, in January, it was only 40% of people were getting that treatment within 31 days. By March, it was 66%. And by May, haven't got June yet, but by May, it was 77.8% getting their treatment within 31 days. So we're working on it. We're trying. We know it's not good enough, and we've got more work to do.
Thank you, Frankie. So that's nearly 8 out of 10, and we want to get it to 10 out of 10.
We do.
Yep, but we're absolutely going in the right direction. Okay, that's really helpful. Thank you. Now, we have a question on autism from Claire Smith, and I know Claire is here, so yeah, Chris, if we can just take the microphone to Claire.
Thank you very much. I actually put in 6 questions, so if I may, I would like to focus on 2, and I'll start with the autism one. When my family moved to Norfolk just short of a decade ago, it was immediately after 2 members of my family had been diagnosed with autism. We found that the autism diagnostic service in Norfolk was significantly underfunded, and that has got worse. And we found that there was no long-term support and very, very little short-term support. This for a diagnosis which is life-changing. If in virtually 10 years, none of the health service and the council have managed to do anything to improve that, is there any chance that this is something you might prioritise and address now?
Thank you, Claire. That's, I mean, you and I and some others on this board have participated in discussions and work around this really important issue through the Health and Wellbeing Board over some years now. So what I'm going to do is come to James Bullion, if I may, first on this, and then to Tricia.
And thanks, Claire, for the question. I mean, I certainly think that the CCG before, and the ICS as well before this board, was a regular participant in the Norfolk Autism Partnership Board, and I would expect that the ICB would continue to engage with both that board and more broadly with patients and with people about their experience of services. So I think we should, in a sense, answer your priority question through our continued work and involvement and engagement with those groups, and including, I would expect, the Integrated Care Partnership to begin to look at this issue and treat this issue as a priority. So on your broad question of is this a priority for the ICB, I certainly think it should be, and that it will be, given the given what you've described about both the challenge of improving diagnostic rates and then improving support post-diagnostics. And I think we would and should acknowledge that the levels of identification and diagnosis do need to improve, and significantly. I mean, in relation to that, the ICB and in fact Norfolk County Council as an integrated provider is in the process of working up an action plan on post-diagnostic support. There are some elements of good delivery at the moment. So, for example, the Norfolk and Suffolk Foundation Trust has got a recovery college model which does offer support to people. But I think we should acknowledge that the post-diagnostic support is something that does need further work, further consideration. And that relates not just to, I think, adult services, but to children's services as well, where in fact the waiting times have recently been going up rather than been going down. So I think we would acknowledge that the last 10 years, as you say, has been a difficult period. I've no doubt as well that the period of COVID-19 will, in a similar way to cancer and other health conditions, will have exacerbated people's experience of the need for support, and no doubt will have increased pressure on services with the existing backlogs, both within the NHS and in fact within the care system as well.
Thanks, James. Tricia, would you like to add anything?
Well, thank you very much, James, for going through a lot of the detail there. Thank you, Claire, for submitting such an in-depth question. And I know that we had the opportunity to talk earlier that we will be responding in detail. But also, I'm absolutely happy to commit to undertaking a review with my colleagues in the local authorities as to where we are at this time and what we need to do differently for the future to ensure that we have robust services to support people with autism. So, as I'm relatively new, I think it's day 1 or 2 or maybe 3 today, I haven't got the in-depth response that Claire, I would expect would want to see, but what I'm more than happy to do is to commit to doing more work to understand the challenges better and to working with Claire around those areas.
Thank you.
So I hope that's sufficient, Claire, today.
Thank you, Tricia. Thank you, James. Claire, I think you said you had a second question. Would you mind, because I'm just conscious of time here, so if you don't mind, I'm going to move on to some other questions. We can come back to you if there's a bit more, if there is enough time. Now, we have a question on information sharing, which is really rather important. And again, I'm just wondering whether the person who submitted that question is here and would like to ask it themselves. Don't think so. Let me just read it out in that case. In the new partnership, how can I make sure that information that's shared is 100% accurate? Talking obviously about personal information. Information in the past has not been ultimately on the part of adult services, and that's led to issues with them, as there seems to be no way to delete incorrect information. So I no longer feel that they're trustworthy, and I'm reluctant to share information other than the most basic information with anyone. And I'm not the only person who's reluctant to share information. I know many others in the Norfolk and North Suffolk area who feel the same. So this is almost the converse of what we were discussing with Belinda and Sharon. There's not enough information in the system about carers. Here's somebody who is very reluctant to share information. Now, where is Stephen sitting? There you are, Stephen, sorry. Stephen, as our new finance director, you're going to have some overall responsibility for this, so it'd be useful just to have a general comment on it.
Thanks, Patricia. So firstly, I'm sorry that's the experience that somebody's had and many have described around information, but just to give some assurance around what all of the organisations within the integrated care system have to adhere to. are around the General Data Protection Regulations and the Data Protection Act of 2018. That means that all of their organisations in the integrated care system have to follow procedures in line with the Information Commissioner's Office and those pieces of legislation. What that means is that if you feel you don't have correct information with our organisations in the system, that you have something called the right to rectification. So you can contact those individual organisations and have a conversation about how we can rectify that information so it is correct. There are some exceptions to that with NHS organisations. I won't go into the full details of those, but essentially there's a statutory obligation for NHS providers to hold information to enable them to carry out their duty of providing health care. So that's known as the right of erasure, so we can't just simply delete information because of that statutory obligation. But what I would say is that you can contact individual organisations with whom your information sits should you have any concerns around its validity, accuracy, and they should have systems in place, will have systems in place that comply with GDPR and the Data Protection Act to ensure that the information we hold is relevant and accurate.
Great, thank you. And of course, as we introduce the shared care record, this is going to become very important because the information does need to be accurate, given that people looking after each of us will be able to see it in order to give us better care and support. Patrick, you, I think, see this from the Health Watch.
I can talk a little bit about the Health Watch perspective. Health Watch is a statutory body across the UK. Health Watch Norfolk is one of the larger, and I'm very proud to say one of the more proactive organisations in the country. And Health Watch's job is to be the voice of the patient. And we can only represent the voice of the patient if we hear from the patient. But one thing that Health Watch is committed to is maintaining anonymity where that's appropriate. So it's very important that people feel confident that they can share their experience with members of Health Watch that are asking for their views on their experience and the experience of their loved ones, so that we can represent their voice fully and strongly and objectively to the health and social care providers in Norfolk and Waveney, and indeed further up the tree, because the information that we collect and that we report on is then shared with Health Watch in the region and up to Health Watch nationally, which is of great interest at the Department of Health and the Secretary of State for Health. So while on the one hand people may be concerned about the accuracy of the information that is against their personal record, I would encourage everybody to feel confident to share information about their experiences with Health Watch, whether it's in Norfolk or Suffolk or wherever you may be, because it will make a difference. And as Patricia has said, I think the shared care record is going to be a huge step forward from the point of view of being able to make sure that, first of all, the patient only has to tell the story once, and secondly, that the health and social care providers have got a full picture so that they can advise on what the best care is for the individual. Thank you.
Patrick, thank you very much indeed. Really helpful. Right. Now, we have the fourth question that was submitted in advance is around safeguarding. And again, I'm just wondering if... Oh, brilliant. Would you just introduce yourself if you'd like to?
Good morning. Oh, you can hear me. Thank you. Thank you for the opportunity to ask this critical question, I think, that informs the work of the ICB and all of our partners. My name is Walter Lloyd-Smith. I'm the manager to the Norfolk Safeguarding Adults Board, and on behalf of Heather Roach, our independent chair, and all board members, we are pleased to see the board start its work. Every child, young person, and adult in Norfolk and Waveney has a right to live their life free from abuse and harm. I think that's something we would all agree. However, that's not the experience. And one of the things that is very, I think, key for the discussion and the board meeting this morning is you've talked about health and well-being, happy and healthy lives. And living a life free from abuse and harm is central to that. So I'd just like to ask the board, what opportunities do you see going forward in all the work that you need to do to embed safeguarding in that, bringing safeguarding and the opportunity for people to live their lives free from abuse and harm as everyday business? And I would just welcome a few thoughts from the board about how we can do that together as a system. Thank you very much.
Absolutely, and thank you very much indeed for that question and the work you're doing on the Safeguarding Board, because I recently had the opportunity to attend the launch of Flourish and this is Norfolk rather than Norfolk and Waveney, but the Norfolk Children and Young People's Strategic Alliance, which of course we are part of, and you are part of, the Safeguarding Board is part of, and that is absolutely critical work, because ultimately all of us as citizens and residents, as well as our professional colleagues, have a responsibility and a role to play in helping children and young people to grow up safe and to flourish. But I'm going to come to Tricia again on that point, and then I see Emma wants to make a comment as well. That's great. Tricia.
So thank you very much for the question, and it plays very much to the agenda, I think, that comes from the Director of Nursing's responsibility to the ICB, and that's to make safeguarding everybody's business. Now, obviously, we have differing arrangements for adults and for children. We need to think about the existing arrangements that are in Norfolk and Waveney. How are they working, which I understand are quite well, but how can we enhance those further, and how can we really embrace the strength of the partnership so that we have a golden thread around safeguarding flowing through everything that we do? Are we confident that everybody that's engaging with our vulnerable adults, with our children, really understands what they should be looking for, and how do they escalate concerns if indeed they have any? And it will be my commitment to the board that we will ensure that there's regular reporting around safeguarding, the themes and trends, what the recommendations should be to the board with how we can work differently together for the future. But I was so pleased to see this question today, because safeguarding is something that we cannot not focus on as a board, or it will be to the deficit of our local populations. So I would really welcome meeting with yourselves to have further discussions, but this is certainly something that needs to be at the forefront of the thinking of the board, Patricia.
I just really wanted to make a comment about the opportunities really that the ICB brings, particularly around safeguarding. As we know from the VCSE sector, we quite often work with the most vulnerable exploited individuals, and not having previously been round a system table, it's been very difficult, as we know, to get information shared, particularly with health and social care partners. So I think the fact that the VCSE sector are now officially around the system table, I would like to think would really help with that safeguarding, particularly with our most vulnerable individuals in Norfolk and Waveney.
Thank you. Right, now at this point, and I'm really grateful to people for submitting those questions in advance, but we've plenty of time for other questions. So are there questions from people in the room with us? Right, no, Claire, I've got you on my list as well. Come back. Let's take gentleman at the front here. We've got roving mics, so we'll just...
Hi, can you hear me?
We can.
Yeah,
and just introduce yourself if you'd like to.
So my name's Kevin James. I wanted to ask a question about health inequalities around severe mental illness and physical health checks in primary care. So I'm from an organisation called Equally Well UK, which is a collaborative between Rethink Mental Illness and the Centre for Mental Health. And we focus on raising awareness around health inequalities for people with severe mental illness, especially people who are using mood stabilising medication that cause significant weight gain. that lead to mortality gap, where most of us tend to die 15 to 20 years younger than others in society as a result of diagnosis, treatment, and poor interventions to support us to lead healthy, long lives. And severe mental illness and physical health checks in primary care are one of the ways of making sure that we do lead and live long, fulfilling lives. We do have a clinical group that's chaired by Professor Wendy Byrne from the Royal College of Psychiatry, and we have a lived experience practitioner group which I facilitate and lead. What more can we do, or what can the ICS do to help close that mortality gap that exists? Not enough is doing in respect of uptake of people in communities taking up the offer of an SMI physical health check. There used to be a CROF payment for primary care and GP practices in respect of people being written to in the community and invited in for a physical health check. I'm happy to say now, working with NHS England, that GP practices now no longer get paid until they've actually carried out the physical health check and discussed the outcome. But quite often people don't feel enabled or empowered, don't even know that these lists exist at GP practices or how to even get access to them. What commitment can you give that will help us to raise awareness around smoking cessation, living long lives, and to help close that mortality gap and increase the uptake?
Kevin, thank you. It's just great to have a question about this really horrifying gap in life expectancy. You were talking about men with particular mental health issues. It's true for people with learning disabilities, where there is a shocking gap in life expectancy. It's also, of course, true for people living in our most disadvantaged families and communities. So I think on this one, let me come to Hilary, perhaps. First of all, for a perspective from primary care as a GP.
Thank you. Can you hear me? The first comment I would make is, obviously during COVID, lots of things didn't happen that we would have wanted to happen, and a lot of face-to-face checks, which, you know, this is what needs to happen for this kind of check, were essentially put to one side for a time. However, over the last 6 months or so, there has been a real focus on this and a lot of discussion about this and how to increase the rates of getting these checks done. So the checks are happening again, and practices have been asked to prioritise this because of the importance of this work. Extra capacity has been brought in across Norfolk and Waveney to try to get the checks done more quickly, and practices have been encouraged to participate in that. Uptake is a real challenge. One of the things we really face problems with is we contact people by a variety of means repeatedly, and getting people to come in and engage with these checks is actually really, really difficult. So if there is some learning, some wisdom, some other things that we can do that would make that, we can have a conversation. We also have a broadened primary care team now, so we've been using people like our social prescribers to try to connect with people, to encourage people to come in for some of these types of checks. But you're absolutely right, I'm sure there's much more that we can do, and we do recognise that this is a really important piece of work.
And can I, forgive me, Kevin, let me just get a comment from Stuart as well.
You know, it's really pleasing, you know, in Tracy's opening comments today, mental health is an absolute priority for us as an integrated care board. And for me, this isn't about us just relying on our primary care colleagues. This has to be everybody's business. Everybody who lives across Norfolk and Waveney, all services, we all have a responsibility to look after our most vulnerable people, and that has to be our focus. So I think we've got real opportunities now, Kevin, to do things differently, moving away from that very traditional provider-commissioner split to one where we're all focused on the same thing, improving the health of the people in the county. So I think it's quite exciting, and I think there are opportunities here to do things very, very different.
Quick comment, Kevin, because I'm conscious of other questioners. We will be able to, I'm sure.
Is it working now?
Yeah.
Yeah, I mean, so just a positive challenge to say that uptake was less than 25% pre-COVID. An acknowledgement that there are other commissioned services alongside primary care and secondary services that have been brought in to help. I don't think it's joined up and that those services are talking to each other, so that might be a really good thing to bring a county-wide working group around SMI, fields of health checks and health inequalities together. And just simply an example of the power of involving people with lived experience that brings around change. One of the things that our working group did nationally with NHS England was to advise GP practices to put these SMI physical health check invite letters into white envelopes rather than cheap brown envelopes, because nothing good comes in a brown envelope news-wise, and people tend to put it on the side and it migrates to a bin. It might be a council tax bill or something of that nature from a DWP. So just simple changes are really effective, and it's about how we engage the patient voice to help us be solution focused.
Kevin, thank you. And could you make sure that you give one of our team your email address before you go? Sorry, we're going to have the microphone back here, please. Other gentleman, I think you had your hand up, did you not? But Kevin, please just make sure so we can follow up with you after this. Thank you.
Hello, can you hear me?
Yes, we can.
Yep, lovely. My question is, could you tell me whether private companies are going to be excluded from the board or NHS services, please?
Thank you very much for that question, and I know there's a sort of national campaign around this, and I'm sure, as you'll be aware, that the Health and Care Bill, when it was going through Parliament, was amended to make it clear that nobody can, probably have to check the exact wording, but essentially when we are appointing people to the board, we have to ensure that nobody's, if we're considering somebody who has some involvement in a private company, or indeed a not-for-profit, a social enterprise company, that their involvement in the board would not compromise the independence of the NHS. And I can assure you, we have applied that provision in appointing the board, and we will continue to do so. It's a really important point, so thank you.
Okay, thank you very much for your answer. Thank you.
Now, do we have other? Yes, there's a. Thank you, lady over there. Thank you. Just hold it close to your mouth. And
yes, thank you very much indeed. My name is Ros Peedle. I'm part of a volunteer team of ambassadors, carers ambassadors, working with Sharon and her team. I just want to make a comment and urge you to move, please, if I may. And then if you will excuse me, I have to leave to go to another meeting in King's Lynn. So I'm a little bit on the run today. I apologise for that. I've heard the words recognised, regarded and respected referred to in connection with carers. And I am much encouraged by that principle. And I hope that that will be continued and pursued throughout the work of the ICB. You've already heard how much money we save, and it is very helpful if we can be respected in that way. Unpaid caring is often a full-time job, and I speak as someone who's cared for, lives with Alzheimer's. So I'm perhaps in the less acute group that James was referring to earlier on. And James is worried about the health of carers, mental health of carers. And I think this is very much a hidden concern from us very often. We do the job, and we often don't realise how much of a toll it's taking upon us, particularly mentally, but also physically. I've been involved in many of the discussions on the passport, and there was a point where we were hoping to roll it out at the Carers Conference in June, and everything appeared to be set for that. And I think I and my colleagues were very disappointed indeed that it then became a circular motion and nothing happened where we thought it was going to. So I think I would urge you, if you have any influence in these matters, to find a simple way to roll this out from one central point only very soon.
Well, Ros, thank you very much indeed for the work you're doing as a carers ambassador, as well as for that question. And I hope you felt, in the response and the interest that we all had in what Sharon and Belinda was telling us earlier. We will absolutely do what we can. I'm not going to promise something that I'm not sure exactly when and how we will deliver, but absolutely with Tricia Dorsey, our new Director of Nursing, in the lead on this, we will absolutely do our best to get this moving.
Thank you very much.
Okay.
It doesn't have to
and
be
I think
complicated.
the fact that you have to leave and now get to King's Lynn for another meeting is a rather nice link, really, to a question we've had online. It's a question about provision of local services in rural communities. It can be very challenging for older people, but not only older people, particularly when accessing appointments early or late in the day at one of our hospitals, where you've got to allow, the time to get up and dressed. You've got to find the transport, and you may be relying on a neighbour or on a community volunteer to get you there, but the hospital needs you there for 8 in the morning, 9 in the morning, whatever it is. And is there something we can do about this, is what the questioner asks. Frankie, I think I'm going to come to you on that one, because it is, I've heard this from elderly neighbours in the village where I live, up in West Norfolk, and it's quite an issue.
So I suppose there are a few different things that I could highlight that we're doing. The first would be retaining flexible appointments. So although a lot of people will need and will prefer face-to-face appointments, actually virtual appointments are good too. And so in my clinics, when I'm arranging to see somebody again, I always say, which would you prefer? Which works for you? Because as a healthcare professional, it makes very little difference, actually, whether the person is here in person, on a screen, or by telephone. So that's one thing, and a lot of people who live rurally are very appreciative, I think, of virtual appointments sometimes. But of course, they're not appropriate for everything. So the next thing we need to do is be more flexible in our approach. And so I would always encourage anybody with an appointment. Well, we have a commitment across the NHS to always agree appointments. And so if an appointment comes through the post, actually that's not okay. You do have a right to have a mutually agreed appointment time. So if it comes through for 8 a.m. and you live 45 minutes away and Bob next door needs to drive you, then remember you do have that right. And if you miss the appointment because it was imposed upon you, as it were, you won't be discharged. It should be reorganised for you. And I think, so that's two things. Firstly, virtual appointments where it's suitable. Secondly, agreeing a mutually convenient time. And thirdly, we are gradually moving to personalised outpatient appointments and patient-initiated follow-up. So rather than having your magic follow-up appointment at 6 months or at 12 months, there's nothing magic about a 6-month or a 12-month time point. You'd probably much prefer to be seen when your chronic condition has deteriorated, or when you're worried about that your asthma's got worse, rather than automatically having it every summer when actually your asthma's fine in the summer. It tends to be much worse in the winter. So that would be the third aspect I think I'd draw out.
Thank you very much indeed, Frankie. Right. Yes, there's a question over there, please, and I'm conscious of time here, so...
I was going to say I'm not very good with technology, but thank you, and thank the board for letting me have this question. My name's Helen Cox, and I'm a clinical nurse specialist at James Paget Hospital. I've been running the stoma service there for a number of years, as well as in partnership with East Coast Community. And we also run the stoma service on discharge from the Queen Elizabeth. And my question and my challenge to you guys up there is really around health equalities or health inequalities. When a patient comes into James Paget, they get looked after by my team on discharge in the community. If they live outside what used to be the old Great Yarmouth and Waveney CCG, they'd go across the border, and then they would no longer be looked after by the team of nurses that had nursed them pre-operatively, peri-operatively. We have to discharge them. What I'm hoping is with this integrated care board is that patients can choose the group of nurses that they want to continue with their care for continuation, and as Tracy said, breaking down the boundaries and transferring that care over. Our service that we provide from a nursing service is CQC registered, outstanding, and my concern is that the patients I discharge into other areas are not going to get the same level. So that's my question to the board about looking at quality service for stoma patients, because my patients are often the underestimated population, and there's 5,000 of them across QE and James Paget. Thank you.
Helen, thank you very much for the question, again on this theme of inequalities, but thank you for the work you're doing as a stoma nurse, because that is, you and your team, absolutely critical. This may be a little too detailed. I'm not sure whether Frankie, I'm just wondering, it might make more sense, Helen, for us to take this away, and we can email you with a response or a more detailed response. But for me, listening to that question, there's a critical point here about making sure that wherever you live in Norfolk and Waveney, you can get the same high quality of care. You mentioned East Coast Community Health, which obviously only works within Great Yarmouth and Waveney, but we need to make sure whatever the service is and whoever it's provided by, every patient can benefit from the same quality. Does anyone on the board want to comment on the more specific? Oh, Tricia, sorry.
Talking a lot today, I do apologise. Helen, as you know, we caught up earlier, and I'm new to the area. What I would really welcome is having the opportunity to come and talk to you about the issues that you're raising. I think Patricia is absolutely right. It's about having that equitability of service to all individuals that are experiencing a long-term condition. But I'm also very interested in how we can take the learning from your team, which is providing that outstanding service, and transfer that learning to other teams as well within our system, so that we've got a much more equitable offer for the individuals across Norfolk and Waveney. But more than happy to change details and catch up outside.
Thank you. Great. Thank you, Helen. Thanks, Tricia. Claire, you've been waiting very patiently, so just nice and brief, if you wouldn't mind, your second question.
Just before the meeting, I had a quick chat with Stuart and Tricia, and they were both graceful enough to acknowledge that before I put in this question, they'd never heard of this. But I'm going to take a wild guess and reckon that I don't think anybody on the board knew about this condition, even though 10% of the population have it. It's called alexithymia. And my question was really to put this into your thinking, to put it on your agenda, because I realise that it is not recognised by doctors and nurses across Norfolk. It doesn't get identified. The single centre of excellence that England has for it has just been disbanded. There is nowhere for people who have this condition to be treated. Given that that's 10% of the population, so that'll be 6 or 7 people here in this room today, I'd like to ask you to address that and to try and spread some knowledge about alexithymia. Thank you.
Thank you very much indeed. My sense is that public but also medical and professional awareness and knowledge about neurodevelopmental conditions is growing fast, but a lot of us are behind the curve, because the science is also changing very rapidly. I don't know, looking to Tricia again, whether she or Frankie or Hilary, Stuart, whether one of you would like to comment on this. Stuart.
Thank you, Claire. Learned loads from our conversation, and as Patricia says, there's lots of developments around neurodevelopment pathways that are taking place across the ICS, but I think we need a conversation offline here to talk about, understanding more who this actually impacts on and how we can work together with the services we currently provide to make sure there is that awareness. So I'm very happy to meet up and talk more, because I enjoyed our conversation. Thank you.
I'm afraid that does bring us to the end of our Q&A session, and indeed the end of, almost the end of this board meeting. Is there any other business from board colleagues? Don't think so. Well, can I just close the meeting by thanking obviously my board colleagues, thanking all of you for being with us today. Really enjoyed being able to talk informally as well as in the more formal confines of this meeting. Thank you to everybody who's been watching the live stream of this meeting. It's really great. We've had, I gather, around 250 people watching the live stream meeting. So I really hope you've all found it helpful, whether you're in the virtual or the physical room. But we would absolutely welcome your feedback on the format of the meeting, the agenda and so on. That would be extremely helpful. And I want to thank all the staff who have worked so hard, our own ICB team and the King's Centre staff, to make this morning possible. It's a more complicated kind of meeting than normally happens, and I think has been a really valuable one. So thank you to everybody for their extremely hard work making this possible. Thank you all, and I look forward very much to seeing you all again and working with you as we take our new health and care system forward. Thank you.